Hello Jomir, all the best for your exam. So these are your revision notes for quick revision. Today we will be discussing bacterial infections of oral cavity. And here we will see scarlet fever, diphtheria, TB and leprosy. Bacteria are unicellular organisms. Certain bacteria produce diseases which are also manifested in the oral cavity. Some of these are produced by specific organism and are of specific nature, while others are clinically specific but may be produced by any of the broad group of microorganisms together. Coming to the structure of bacteria, from the most outside we have pilus, then we have flagella, then we have cell membrane here and cell wall and cell membrane, then the nucleoid which has DNA, it does not have any nuclear membrane, and the ribosomes because we don't have any organelles. So coming quickly to scarlet fever. Scarlet fever is also called as scarlatina. Scarlet fever is also called as scarlatina. Scarlatina. The causative organism is Streptococcus pyogenes. Streptococcus pyogenes, it's a beta hemolytic organism. It produces exotoxin. So what is the pathogenesis? The bacteria, it enters the pharynx and produces exotoxins such as A, B and C. These exotoxins, they do hypersensitive reaction. They cause hypersensitive reaction. So it produces the rash that we will be studying. So it's very much common in young children and the incubation period is about 3 to 5 days. The route of entry is oral. The clinical presentation, very characteristic, is the scarlet skin rash. Scarlet skin rash, it happens around the 2nd and 3rd day and prominent in the areas of skin folds. These areas of skin folds are called Bacterial lines. It blanches on pressure. Blanch on pressure. First it appears around the upper trunk and then it later goes through the extremities, but it does not involve the palms and soles. There is something called a sandpaper feel of skin. What happens? The small papules of normal color erupt through these rashes that we saw. So it is called a sandpaper feel of skin. Rash subsides around 6 to 7th days. It started at 2nd to 3rd day and subsided around 6 to 7 days. After the rash subsides, there is something called as desquamation of the palms and soles. Other non-significant features such as fever, headache, chills, abdominal pains, vomiting and cervical lymphadenopathy. So we come to the oral manifestation. The oral manifestation is also called as stomatitis scarlatina. Oral manifestations are also called as stomatitis scarlatina. The things that we should remember are Forshamer spots. Forshamer spots, strawberry tongue, raspberry tongue. Forshamer spots, strawberry tongue and raspberry tongue. Forshamer spots are small punctate red macules. Small punctate red macules. These appear on the hard and soft palate and uvula most commonly. Swelling of tonsil and faucicular pillars may also be seen. Swelling of tonsils and faucicular pillars, pharyngitis. And in tongue, early changes, strawberry tongue. What happens? There is edema of the and hyperemia of the fungiform papilla, and there is a white coating on the tongue. So through this white coating, the papilla projects as red small knobs. That's why we call it strawberry tongue. It looks like a strawberry. Late changes, we have raspberry tongue. The white coating of the tongue is lost and the entire tongue now shows as red glistening smooth hyperemic papilla. Plus there is hyperemic papilla, so because it is just reddish and like that, so it's raspberry tongue. Coming to the diagnosis, confirmatory is by culture from the intraoral lesions. Other blood findings such as marked leukocytosis, increased neutrophils, elevated ESR and elevated C-reactive protein. These can also be found, and in the treatment we give antibiotics such as penicillin, dicloxacillin, and cephalexin, and local application of mupirocin may also be done. So this is scarlet fever. The few words that we should remember in scarlet fever is that scarlet skin rash, 2nd, 3rd day, Bacterial lines, sandpaper feel of skin, desquamation of the palms and soles after that, and then oral manifestations, stomatitis scarlatina, Forshamer spots, hard soft palate, tongue, strawberry tongue and raspberry tongue. Then coming to diphtheria. Diphtheria, in the olden days, some words such as Egyptian ulcer, Syrian ulcer and the strangling angel of children were used in relation to diphtheria. It is a acute, life-threatening, infectious and communicable disease of the mucosa and skin. The causative organism is Corynebacterium diphtheria. Corynebacterium diphtheria. It is anaerobic and gram-positive. Transmission is through respiratory droplets, and it is airborne. Direct skin contact can also transmit. Incubation period is about 2 to 5 days for the respiratory symptoms, and 7 days after the primary lesion, the cutaneous lesions may arise. So coming to the pathogenesis of diphtheria. Diphtheria, the bacteria, it's generally airborne, so enters through the mucous membrane of the respiratory tract, but it can also enter through open wounds or insect bite. So the bacteria, it multiplies at the site of origin and releases toxins. These toxins cause edema and hyperemia and acute inflammation. By this inflammation, there can either be coagulation of fibrin and present exudate produces pseudomembrane. This pseudomembrane has dead cells, leukocytes, erythrocytes, and bacteria. Or it goes to systemic toxemia, then we have myocarditis, neuritis, focal necrosis in various organisms. So either it will form pseudomembrane by this coagulation of fibrin and exudate, or systemic toxemia. So coming to the clinical features, the characteristic, that is pseudomembrane. Characteristic feature is pseudomembrane. This pseudomembrane is seen on the tonsils. It appears as washed leather, elevated grayish-green membrane. Washed leather, elevated grayish-green membrane. Well-defined edges are there and well surrounded by the inflammation. If there are diphtheria patients, if they have pseudomembrane, we call them diphtheria patients. If the pseudomembrane is not clinically present, we call them diphtheria carriers. Swelling of the neck, classic bull's neck can be seen. Tender enlargement of lymph nodes may be there, and other features like fever, sore throat, weakness, dysphagia, headache, change of voice. In cutaneous skin lesions, we see punched out ulcers with leathery discharge. Punched out ulcers with leathery discharge. Coming to the oral manifestations of diphtheria. Oral manifestations of diphtheria. We have to remember diphtheric membrane. Again, other name I believe for pseudomembrane. So we have begins on the tonsils and enlarges, becomes confluent over the surface, grayish green, thick, fibrinous, grayish green, thick and fibrinous. It is very adherent. It leaves a bleeding surface if stripped away, and the advancing border is red, obviously because it is surrounded by inflammation. And we can also have non-specific ulcers. In the soft palate, there may be temporary paralysis. In the soft palate, there may be temporary paralysis. And around the 3rd and 5th week of disease, nasal regurgitation of liquids during drinking, peculiar twang. Peculiar twang can also be there. Then coming to unchecked infection, if we do not undergo any medication or any maintenance, the larynx may get involved. Once the larynx is involved, there will be edema of the larynx, husky voice due to the pseudomembrane presence in the larynx, which will cause mechanical obstruction, and a typical cough named as diphtheric cough. Diphtheric cough may be present, and if it is still not treated, there can be suffocation and the patient may die. So the treatment of diphtheria is antitoxin. Diphtheria antitoxin is given. Diphtheria antitoxin neutralizes the circulating diphtheria toxin and prevents disease progression. And we give antibiotics, and obviously air maintenance is very important. In prevention, we can say diphtheria toxoid vaccine, which is DPT vaccine, can be given. Then coming to tuberculosis. Tuberculosis is a specific infection, granulomatous disease. Specific infectious granulomatous disease. The causative organism is Mycobacterium tuberculosis. Mycobacterium tuberculosis. Mycobacterium tuberculosis is a rod-shaped, non-sporing, acid-fast bacilli, facultative intracellular parasite. So coming to the pathogenesis of TB. What happens? First, there is inhalation of the droplet nuclei. The droplet nuclei means a droplet in which there is TB, some from the other person who is infected. About 90 or more than, maximum of them, they get trapped and exhaled by the ciliary action, so no disease is produced. Around less than 10% of this may reach the alveolar macrophage. Once it reaches the alveolar macrophage, the bacteria multiplies and forms granulation lesions, which are called as tubercles. Granulation lesions, which are called as tubercles in the alveolar macrophages. Then what causes active primary infection in the lung? We call this as Ghon's focus. Active primary infection in the lung is the Ghon's focus. And then it may go to the lymph node, where it can form Ghon's complex. And here, if the lesion heals slowly through fibrosis or even calcification, Ranke's complex, and there can be liquefaction, and then the lesion can heal, or in poor immunity, it can spread through the hematogenous route, and we call it miliary TB or tuberculous meningitis. So clinically, we have two types of TB, pulmonary TB and extrapulmonary TB. The extrapulmonary means outside lungs, lymph nodes, pleura, GIT, bones, meningitis, anything can be involved. In pulmonary TB, we have primary, post-primary or secondary, and miliary TB. So what are the features? In primary TB, it is more common in children. It is asymptomatic, or we can sometimes see febrile illness, cough, which can be dry or productive. In post-primary or secondary TB, we'll have regular cough, fever, chest pain, and hemoptysis. In miliary TB, if it is in children, it will cause acute febrile illness. If it is in adults, we can see that development is a little more gradual. Fever, anorexia, loss of weight, hepatosplenomegaly, and lymphadenopathy. Then, coming to the few terminologies like scrofula and lupus vulgaris. Scrofula is the tuberculous infection of submandibular and cervical lymph node. Submandibular and cervical lymph node. This will show scrofula. We will see swelling there. So it will show as a typical granulomatous lesion, or sometimes it can progress to form abscess. A typical granulomatous lesion or progress to form abscess. It is pain, tender, and there is swelling of the nodes. Often the overlying skin may be inflamed, and then it can perforate and produce some discharge. Then comes lupus vulgaris. What is lupus vulgaris? This is the primary TB of the skin. There are papular nodes which frequently ulcerates, and it is very common in face, but it can occur anywhere. Then comes to the oral manifestations of TB. Primary and secondary. In primary, the most common area is gingiva. In tongue, the most common site is tongue. In secondary, the most common site is tongue. So we have diffuse, hyperemic, nodular or papular proliferation of the gingival tissue. In primary TB, it is in gingiva. We have diffuse, hyperemic, nodular or papular proliferation of the gingival tissue, and lymphadenopathy. In secondary tongue, we have irregular, superficial, deep ulcers, which tend to increase in size and slowly. So ulcer in secondary, and in gingiva, some kind of proliferation. TB of maxilla and mandible may also occur. What happens is in the periapical tissue, how the organism will reach either directly through infected bloodstream, means the bloodstream that is coming at the beneath the tooth, then through open pulp chambers from the oral cavity, and post extraction also from the oral cavity. These periapical tissue, in this the periapical tuberculous granuloma may form. Periapical tuberculous granuloma may form, and then tuberculous osteomyelitis may progress and it has an unfavorable prognosis. Histopathology, we have granuloma tubercle, foci of caseous necrosis, epithelioid cells, lymphocytes, multinucleated giant cells, plus Langhans cell. Coming to the diagnosis, the gold standard is presence of acid-fast bacilli in the sputum. Supplemental tests such as chest radio, CT, especially for miliary TB, and MRI for extrapulmonary TB is done. Microscopic smears and the stains that can be used as Zn stain, Quinion's cold staining, and Rodaman staining for the fluorescent microscope. A minimum of 3 acid-fast bacilli on Zn stain is positive, and a minimum of 5 on fluorescent microscope is considered to be a positive diagnosis. Then Mycobacterium culture. The conventionally we use Lowenstein-Jensen medium, or we can also use Middlebrook medium. These give a 4 to 6 week report. And other, if we want a faster result, we have rapid slide culture technique and radiometric culture method. Radiometric culture method. Then comes to tuberculin test or Mentu test. About 0.1 ml of tuberculin is inserted. Subcutaneous infection in the forearm. Around after 48 hours, we check whether there is induration or not. So this induration is not seen as the redness, rather we have to do the palpation, whether there is induration or not via the palpation. So if it is more than 15 mm, it is strongly positive, more than 10 mm positive, 5 to 9 mm indeterminate, and less than 5 mm is negative. If it is indeterminate, we should do it again later. Other methods such as PCR, ELISA, RIA, radioactive immunoassay can be done. So the recommended treatment is DOTS, which is directly observed treatment, short course. Tablets such as isoniazid, rifampicin, pyrazinamide, streptomycin, ethambutol. Rifampicin, pyrazinamide, streptomycin, and ethambutol. Then MRD TB is multi-drug resistant TB. XRD TB is extensive drug resistant TB. Then we come to leprosy. Leprosy is a chronic granulomatous infection, also called as Hansen's disease. Causative organism is Mycobacterium leprae, which is gram-positive in acid-fast bacilli. So, what is the difference between M. tuberculosis and M. leprae bacteria? Here it is slightly straight or curved. This is also very similar, but this is longer and thinner. Tuberculosis is longer and thinner. Leprae is shorter and thicker. The individuals in tuberculosis is parallel cords, arranged as parallel cords, pairs or individuals, and leprae mostly clusters, and it is called as globi. So the acid fastness of tuberculosis is strong. So we need about 20% of H2SO4, and leprae are weakly acid fast, so we need around 5% of H2SO4 during the Zeden staining. Then location intracellular, this is found inside and outside macrophages both, and leprae are strictly intracellular, and these are called as leprae cells when these are inside the macrophages. So the incubation period is very long, about 5 years, or it can even take as long as 20 years. It grows best in the cooler tissue such as the peripheral nerve, upper respiratory tract, and anterior chamber of eye and testis. Zeden stain in living cells will look like solid pink rod, and non-living cells will have a granular fragmented appearance. It can be grown well in about 30-33 degrees Celsius in mouse foot pad, and 9 branded armadillo. It can remain viable up to 10 days in environment, and the transmission can be droplets from mouth or nose and through prolonged contact of untreated leprosy. Coming to the pathogenesis. M. leprae, by the inhalation of droplets, bacteria is taken up in our body. So how the bacteria survives in our body? Because we have our own immunity, right? So what happens? These bacterial cell wall has something called as lipoarabinomannan. It inhibits the activation of macrophages. So these bacteria are taken up in the skin by histiocytes and in the nerves by Schwann cells. The outcome, if there are individuals have intense cell-mediated immunity, the tuberculoid type of infection is formed, which has paucibacillary, means low bacterial count. And individuals with low specific cell-mediated immune response will have a lepromatous type of infection, which has a high bacillary count. And in between, something called as an indeterminate type may also be present. So what are the clinical features? In the clinical features of leprosy, the generalized features are hypopigmented patches, partial or total loss of the cutaneous sensation in the affected areas. Sabse pehle, the first that goes away is the light touch. So what is the difference in tuberculoid lesions and lepromatous lesions? The tuberculoid lesions are single or multiple macular erythematous lesions, and lepromatous lesions they are erythematous macules and papules, but progressive thickening of the skin, and then they become nodules, and it also leads to severe disfigurement in the body. Then in tuberculoid lesion, we have dermal and peripheral nerve involvement, loss of sensation, and loss of sweating of the affected skin. In lepromatous, there can be facial paralysis, ulcers, loss of fingers and toes, nasal depression, because obviously disfigurement is there, and foot drop or clotto. Oral manifestations, something called as a leproma. In oral manifestation, we have something called as a leproma, which is most commonly seen in the tongue, lips, or palate. These are small tumor-like masses. It has a tendency to break down and ulcerate. So they can also be gingival hyperplasia with loosening of teeth, trigeminal nerve, maxillary branch and may be affected, and facial nerve may be affected, leading to paralysis. And we call it odontodysplasia leprosa, which are the dental manifestations of leprosy. So how the tooth are affected? There can be circumferential hypoplasia, shortening of roots, pinkish discoloration of crowns, and it is most commonly seen in the anterior maxillary region or the premaxilla. Histopathology, typical granuloma is there, epithelioid cells, lymphocytes, Langhans type giant cell, but there is no necrosis here. Then leprae cells, vacuolated macrophages may be found. It can be tuberculoid or lepromatous if there are less organisms and more organisms. And multi-drug therapy, rifampicin, dapsone, clofazimine is seen.